Chapter 14, Part 2, Diseases of the Upper Gastrointestinal Tract. Gastroesophageal reflux disease define this condition as symptoms or complications result from the reflux of gastric contents into the esophagus or beyond, into the oral cavity or lungs. Each year, more than 20,000 of the US population suffer at least weekly symptoms of gastroesophageal reflux. The frequency of GERD symptoms do not appear to rise with age, but the rate of complication does. GERD is also common during pregnancy. The lower esophageal sphincter, or LES, normally serves as a barrier between the esophagus and stomach. Under normal conditions, atmospheric pressure is greater in the esophagus than in the stomach, and this pressure distinguished between typically prevents reflux of gastric contents. LES incompetence may result from the normal transit relaxation, a change in LES pressure, or some types of anatomical change such that is seen with hiatal hernia. Symptoms of GERD may include dysphagia, difficulty swallowing, heartburn, increased salivation, and belching. In some situations, pain is severe and may radiate to the back, neck, and jaw. In fact, pain from GERD can be confused with pain that is cardiac in origin because of the diffuse spread of pain into the other areas. Medical diagnosis of GERD can be made clinically based on the presence of associated symptoms and their relied after prescription and use of a proton pump inhibitor. Further diagnosis is made by an endoscope. Treatment for GERD includes 3 goals: increasing LES competence, decreasing gastric acidity and thus decreasing the severity of symptoms, improving clearance of contents from the esophagus. Surgical interventions may be warranted if the disease is unresponsive to medical management or if the patient experiences complications. Decreasing gastric acidity involves the use of several groups of medication and, for some patients, nutrition therapy. Medications fall into 5 major categories: antacid or buffering agent, histamine blocking agents, prokinetic agents, proton pump inhibitors, and mucosa protectants. Lifestyle factors that compromise LES competence, such as cigarette smoking, use of educations, obesity, and nutritional history should be addressed. Patient education can focus on ways to improve clearance in the esophagus. For example, patients may be instructed to remain upright after eating, to lose weight, to wear loose-fitting clothing, and to raise the head of the bed for sleeping. The most common surgical procedure used for retractatory GERD is the Nissen fundoplication. This procedure takes the fundus of the stomach and wraps it around the lower esophagus. This provides additional strength to the LES and assists in preventing the reflux. The goals of nutrition therapy are consistent with the goals of medical care. These goals include reducing gastric acidity and the trial of food restrictions, excluding those foods that may lower LES pressure. Nutritional therapy may assist not only by addressing these nutritional problems, but also by decreasing the symptoms that the patient is experiencing. Long-term use of medication for GERD may impair calcium absorption and iron and B12 status. Common nutrition diagnoses associated with GERD include overweight or obesity, impaired nutrient utilization, inadequate vitamin or mineral intake, swallowing difficulty, or altered GI function. Nutrition intervention for GERD: foods that may relax the lower esophageal sphincter include peppermint or spearmint, chocolate, fried foods with high amounts of added fat, alcohol, coffee, decaffeinated and caffeinated, foods that may increase gastric acid secretion include coffee, alcohol, and pepper. Unfortunately, most nutrition therapy interventions that have been used historically have not been tested through rigorous scientific study. Recommendations to reduce gastric acidity typically include a trial of elimination of black and red pepper, coffee, and alcohol. These have been identified as stimulants for gastric acid production. Smaller, more frequent meals may be indicated. Ongoing monitoring is recommended to assess the effectiveness of any food restrictions in controlling symptoms. Again, nutrition intervention for GERD, foods to avoid. Foods that may relax the lower esophageal sphincter include peppermint or spearmint, chocolate, fried foods, or those with high amounts of added fat, alcohol, coffee, that could be decaffeinated and caffeinated coffees. Foods that may increase gastric acid secretion, coffee, alcohol, and pepper. This is table 14.9. It's nutrition interventions for GERD. It gives the food group and foods to avoid if they cause symptoms. Beverages, caffeinated and decaffeinated coffee and tea, cocoa, alcohol, milk and milk products, 2% milk, whole milk cream, high fat yogurts, chocolate milk, eggs, fried or scrambled using high fat cooking methods, cereals, grains, high fat choices such as pastries, meat and protein sources, fried meats, bacon, sausage, pepperoni, salami, bologna, hot dogs, vegetables, only those that aggravate symptoms in the individual, fruits, only those that aggravate symptoms in the individual, fat, as tolerated within current recommendations of US dietary guidelines, less than 8 teaspoons daily, desserts, high fat or fried desserts, miscellaneous, pepper. Barrett esophagus involves a change in the epithelial cells of the esophageal mucosa and is usually considered a complication of GERD. Barrett esophagus is detected in approximately 10% of patients undergoing endoscope for GERD. Patients with Barrett esophagus have been shown to have persistent abnormal pH monitoring results even on maximum pharmacological treatment. Patients do not experience any specific symptoms with this condition outside of those experienced with GERD. It is generally undetected unless the patient has a biopsy done as part of an upper GI diagnostic workup, treatment of GERD. There are no specific nutritional concerns unless the patient is diagnosed with esophageal cancer. Enoesophageal epithelitis is defined both clinically and pathologically using the following criteria. Symptoms consistent with esophageal dysfunction, biopsy revealing greater than 15 eosinophils per high power fields, mucosa eosinophilia limited to the esophagus that persists after a trial of PPI. A response to treatment supports the diagnosis. EOE is a fairly new diagnosis as it was initially discussed within the literature in 1970. This diagnosis does not appear to have a higher prevalence in young men. This diagnosis does appear to have a higher prevalence in young men and is associated with a specific genetic profile. EOE is an inflammatory condition characterized by infiltration of eosinophils with esophageal mucosa. The immune response has been linked to both environmental and food as disease triggers. The American Gastroenterology Association guidelines state that the diagnosis require an endoscope with biopsy revealing greater than 15 eosinophils per high power field. Symptoms of EOE in adults include heartburn, non-cardiac chest pain, dysphagia, and food impaction. Infants and children may present with a history of feeding dysfunction, nausea, vomiting, and abdominal pain. Pharmacological treatment include high dose of proton pump inhibitors, swallowed topical steroids, and systemic steroids. The first is an elimination of all food allergens by substituting a chemically defined formula as the only source of nutrients. This next step of nutrition therapy option include a directed or empirical elimination diet. The empirical elimination diet removes the most common food allergens, which include soy, milk, egg, wheat, peanuts, tree nuts, and seafood. After elimination for 8 weeks, foods are reintroduced one at a time. Dysphagia. Dysphagia or difficulty swallowing is not generally considered a diagnosis, but a symptom caused by a variety of disorders. Since many conditions of the esophagus involve dysphagia, it is important to understand that this symptom and the importance of the nutrition therapy in its treatment. The symptoms of dysphagia experienced by a patient depend on the phase of swallowing that is impaired. Other general symptoms may include drooling, coughing, and choking. Many patients will experience weight loss and generalized malnutrition due to inadequate nutritional intake. Aspiration or inhalation of oropharyngeal contents is a primary complication. Aspiration is a primary complication. Diagnosis and treatment of dysphagia involve many different members of the healthcare team. Diagnosis of dysphagia begin with a clinical bedside evaluation and bedside swallowing assessment, usually performed by the speech language pathologist. Diseases and conditions associated with dysphagia include things such as stroke, closed head injury, Parkinson's, Alzheimer's, Huntington's, systemic lupus. The primary nutritional implications are weight loss and subsequent development of nutrient deficiencies that can result from an inadequate dietary intake. Therefore, it is very important to accurately evaluate anthropometric measures and obtain as much information as possible regarding dietary intake and food patterns. Common nutrition diagnoses include inadequate oral intake, inadequate fluid intake, malnutrition, altered GI function, swallowing disorder, or swallowing difficulty. Once the patient's swallowing ability has been evaluated by the RDN, they can use the food of acceptable textures to develop an adequate menu. The standard definition for food, liquids, and levels of nutrition intervention for dysphagia diet were initially developed by a U.S. task force in 2002. These levels of diet interventions are the National Dysphagia Diet 1, 2, and 3. Guidelines for both food and solids by the International Dysphagia Diet Standardization Initiative provided more explicit guidelines for both fluid and solid foods that have been adopted. Please review Table 14.12, which outlines the foods allowed on each level of the National Dysphagia Diet and the recommendations from IDDSI. Depending on the origin of the patient's dysphagia, tolerance of an oral diet may improve with treatment. The RDN with other healthcare team members will reevaluate the ability of the patient to progress in use of the prescribed diet. Patients' weight, nutritional parameters, and hydration should be monitored closely to ensure adequacy of nutritional intake. National Dysphagia Diet 1, Dysphagia Pureed, equivalent of the IDDS Pureed, food allowed, foods of pudding-like consistency that are smooth or puree with no lumps. Food not allowed, gelatin desserts, fruited yogurts, peanut butter, unblenderized cottage cheese, scrambled, fried, or hard cooked eggs. A sample menu could include pureed chicken, mashed potatoes with gravy, pureed carrots, applesauce, and chocolate pudding. Dysphagia Diet 2, equivalent of the IDDS, mixed and moist. Food allowed. Foods that are moist and soft textured, such as tender ground or finely diced meats, soft cooked vegetables, soft ripe or canned fruit, and soft moistened cereals. Foods not allowed: bread, dry cake, rice, cheese cubes, corn, and peas. A sample menu could include scrambled egg, pancake with syrup, flaked cold cereal with milk, banana, orange juice, beverage thickened as appropriate. Dysphagia diet 2, alternative diets, so a dysphagia mix, term used by some institutions to designate a customized puree diet that also allows one mechanically altered item. Sample menu: orange juice, vanilla yogurt, cream of wheat cereal, scrambled egg. Mechanical soft, alternative diet that allows bread, cake, and rice in addition to the NDD2 mechanically altered diet. A sample menu: diced chicken with gravy, steamed rice, Harvard beets, pound cake, and fresh strawberries. National Dysphagia Diet 3, equivalent of the IDDS soft slash bite size. Food allowed includes most regular foods except very hard, sticky, or crunchy foods. Bread, rice, cake, shredded lettuce, and tender, moist meats are allowed. Food not allowed: hard fruits and vegetables, corn skins, nuts, and seeds. Sample menu could include vegetable soup, shredded lettuce salad with dressing, turkey sandwich with mayonnaise, fresh ripe melon, and chocolate chip cookie with no nuts. National Dysphagia Diet 3, the liquids, terminology recommended by the NDD task force to describe the viscosity of beverages and other liquids. Equivalent terminology from IDDS 1 is listed beside for comparison. Thin is thin liquids. Naturally thickened liquids, supplements, or infant formulas, that's slightly thick. Nectar thick, mildly thick. Honey thick, moderately thick, and spoon thick is extremely thick. Hiatal hernia is a condition where the upper portion of the stomach protrudes through the esophageal hiatus into the thoracic cavity. Symptoms of a hiatal hernia are consistent with those of GERD. Treatment first line intervention, both medically and nutritionally, are the same as those discussed with GERD. Some patients require surgical repair of the hernia. Achalasia is a motility disorder in which there is an absence of peristalsis or a weakening esophageal peristalsis. In this condition, there is often an elevated LES pressure with an impaired relaxation of the LES. The etiology of alkalation is unknown at this time, but at the same time, it appears that an autoimmune destruction of ganglion cells occur after an infectious event. Individuals with alkalation can experience a range of symptoms, including dysphagia, vomiting, and pain upon swallowing. Foods and fluids accumulate in the lower esophagus, causing an organ to become dilated or stretch. Nitrates, and calcium channel blockers can provide temporary relief through their actions on the stomach's muscle. Botulinum toxins have also been used to block acetylcholine, which improves peristalsis. Individuals with alkalasia often experience significant weight loss and malnutrition due to dysphagia and regurgitation. Nutrition education for modifying texture and increasing nutrient density is the primary focus of nutrition therapy. Surgical procedures involving the esophagus are warranted for numerous diagnoses, including Barrett esophagus, uncontrolled GERD, alkalasia, and esophageal malignancies. The Nissen fundoplation takes the fundus of the stomach and creates a wrap around the LES. The esophagectomy resects portions of the esophagus, dependent on the nature of the condition. The goal of nutrition therapy after surgery is to promote healing, prevent any nutrient deficiencies, follows nutrition guidelines for prevention of dumping syndrome if the patient is at risk. Enteral feeding should be continued until the patient is consistently consuming greater than 60% of energy and protein needs orally. Diseases and clinical disorders that affect the stomach can certainly influence nutritional status. Indigestion, nonspecific abdominal distress, nausea and vomiting can be caused by drugs, toxins, metabolic conditions, stress, or extreme emotions. Treatment of the underlying condition or cause is important. Nutrition intervention to reduce nausea and vomiting. Liquids to try after vomiting has stopped include water, apple juice, sports drink, warm or cold tea, lemonade. Instructions: first, suck on ice chips if over 3 years of age. If tolerated, start with 1 teaspoon every 10 minutes, increase to 1 tablespoon every 20 minutes, double the amount of fluid every hour. Progress to the other liquids as tolerated. If diarrhea is present, use only rehydration beverages. Solid food introduction. When there has been no vomiting for at least 8 hours, start oral intake slowly by adding 1 solid food at a time in very small increments. Avoid food that is high in fat or fiber, as well as food that has a strong odor or gas producing. The use of ginger to treat nausea and vomiting may help. Take medication after eating. Foods recommended for initial introduction of solid food. Grains, you could do dry toast, crackers, pretzels, rice or rice cereal, and potato. Milk and dairy products, yogurt and sherbet. Milk and dairy products include yogurt and sherbet. Meat, poultry, and fish, clear broths, baked chicken, and eggs. Nutritional implications: inadequate intake, dehydration, acid-base imbalances, learned food aversions. Nutrition diagnosis could include altered GI function, involuntary weight loss, inadequate fluid intake, and inadequate oral intake. Nutrition intervention should include minimizing symptoms and discomfort and maintaining nutritional status. Gastritis is inflammation of the gastric mucosa. This condition is not a discrete disorder as it may result from numerous conditions. Acute gastritis is typically related to infection, which may be viral, bacterial, fungal, or parasitic in nature. Acute gastritis can also occur with food poisoning, alcohol ingestion, or medications such as non-steroidal anti-inflammatory drugs. Chronic gastritis is classified as type A or type B. Type A involves the development of antibodies against parietal cells and extrinsic factor and is less common. Type B is more common and is related to H. pylori infection. Under normal conditions, the gastric mucosa is well protected against injury. The production of mucus provides a barrier that prevents damage to the cells, and their high turnover rate allows for efficient recovery from injury. Symptoms include belching, anorexia, abdominal pain, vomiting, bleeding, and hematemesis. Treatment focuses on underlying cause. Peptic ulcer disease involves ulceration of gastric or duodenal mucosa that penetrates the submucosa. They usually occur in the atrium of the stomach or in the first few centimeters of the duodenum. In the US, 15.5 million people were diagnosed with peptic ulcer disease in 2011. Peptic ulcer disease accounted for 600,000 healthcare visits and over 350,000 hospitalizations. Etiology. The H. pylori, or spiral-shaped gram-negative rod that lives under the mucosa layer of the stomach and attracts to mucus-secreting cells lining the stomach. Clinical manifestations: the most common symptoms related to peptic ulcer disease is epigastric pain and a burning sensation, but this pattern is not consistent. Patients will complain of abdominal pain and a burning sensation, which may be caused by certain food or the amount of food intake. Nutritional implications is an assessment: impaired oral intake, weight loss, and nutrient imbalances. Nutritional diagnosis could include inadequate beverage intake, altered GI function, involuntary weight loss, and food and nutrition related knowledge deficit. Nutrition intervention: supporting medical treatment, maintaining or improving nutritional status, and minimizing symptoms. Monitoring and evaluation: adequacy of the patient's nutritional intake and the tolerance of an oral diet. When peptic ulcer disease do not respond adequately to medical treatment, or when patient experience a complication of peptic ulcer disease, surgery is often the next step. Vagotomy is to eliminate the calorigenic stimulation of the stomach. Selective vagotomy eliminates innervation from the vagus nerve to parietal cells, resulting in decreased acid production and decreased response to gastrin. Nutritional risk is due to reduced capacity of the stomach and potential change in gastric emptying and transient time when the normal pathway for digestion and absorption is interrupted. Nutrition diagnosis: increased energy expenditure, inadequate oral intake or protein energy intake, inappropriate intake of carbohydrates, altered GI function, impaired nutrient utilization, involuntary weight loss, food and nutrient related knowledge deficit. Dumping syndrome is the most common post-surgery complication. An increased osmolar load enters small intestine too quickly from the stomach. Surgery affects the release of hormones, enzymes, and other secretion. Food dumps into the small intestine if gastric function is altered. This is figure 14.13, the pathophysiology of dumping syndrome. Please know from the starting to the finish of how dumping syndrome can occur. Nutrition intervention: post-gastrectomy diet, encourage a well-balanced diet, slightly higher in protein and fat. Monitor closely for weight loss and symptoms of malabsorption and steatorrhea. Bariatric surgery: the route in Y, the gastric bypass. Nutrition intervention after gastric surgery: prescribe adequate energy and protein intake to ensure appropriate healing and recovery postoperatively. Initiate slow progression of solid food to prevent onset of early and late dumping syndromes. Patients may be initially lactose intolerant and dairy products should be avoided. Slowly progress to 5 to 6 small meals each day. Advise patients to consume liquids 30 minutes to an hour after solid food. Instruct patients to lay down after eating. Consider addition of functional fibers to delay gastric emptying and assist with treatment of diarrhea. Prevent development of nutrient deficiencies. Liquid multivitamin and mineral supplements should be initiated to meet minimally the dietary reference intakes for all established nutrients. B12 injections are initiated if extent of gastric surgery warrants this intervention. Monitor serum levels of other micronutrients and supplement as necessary. Provide nutrition education that will promote optimal nutritional intake and minimize symptoms of malabsorption and malnutrition. Gastroparesis, the syndrome of objectively delayed gastric emptying in the absence of mechanical obstruction. The etiologies are abnormalities in hormones, muscles, and or the nervous system, which controls the gastric emptying. Gastroparesis, sonographic gastric emptying test is used for diagnosis. Clinical manifestations include nausea, vomiting, early satiety, and postprandial fullness. Treatments include acute management and correction of any fluid, electrolyte, or acid-based abnormalities. Pharmacological treatment for gastric emptying, time, and reduction of nausea and vomiting. Nutritional implications, the patients are at high risk of malnutrition. Nutrition diagnoses include inadequate oral intake, inadequate protein, energy intake, altered GI function, impaired nutrient utilization, involuntary weight loss, and malnutrition. Nutritional intervention, modifications of the oral diet, or if necessary, enteral or parenteral nutrition. Gastroparesis nutrition therapy, prescribe adequate energy and protein intake to ensure overall nutritional needs are met. Recommend appropriate nutrition support if progression to solid food does not proceed successfully. Divide foods into 5 to 6 small meals each day. Encourage activity after eating. Tell patient to not lie down after eating. Recommend that all foods be chewed well. Food choices are low in fiber and low in fat. Provide nutrition education that will promote optimal nutritional intake and minimize symptoms of malabsorption and malnutrition. Maldigestion, excuse me. So I'll read it again. Provide nutrition education that will promote optimal nutritional intake and minimize symptoms of malabsorption and or maldigestion. Stress ulcers caused by sepsis, shock, burns, or head injuries. Treatments involve continuous infusion of H2 blockers or liquid antacidants. Zolliger-Ellison syndrome is gastric acid hypersecretion, similar to peptic ulcer disease, but unresponsive to treatment. Nutrition therapy is the major form of medical treatment for upper GI tract function. I say it again, nutrition therapy is the major form of medical treatment for many upper GI tract conditions.